Hi guys, welcome to another lecture and I hope you are all right and we will be taking this lecture. This lecture will be mainly focusing on cerebral palsy and this will be the only lecture you need to watch for cerebral palsy. So let's begin our lecture. So the first thing is, what is cerebral palsy? What is cerebral palsy? Very difficult question or a very easy question. Cerebral palsy is a group of disorders of development of movement and posture, development of movement and posture causing activity limitation, activity limitation that is due to a non-progressive cause, non-progressive or a static insult to the brain, non-progressive or a static insult that occurred in non-progressive insult to a developing brain of a newborn or an infant, developing brain. So this is the definition, primary definition of CP, and there is an additional that motor disorders, the motor disorder of CP, the motor dysfunction in CP, motor dysfunction in CP. The motor dysfunction in CP is associated with abnormalities of sensation, cognition, communication, perception, and behavior, and which is also associated commonly with seizure disorders. So this is the definition of cerebral palsy, and you have to understand that there are lots and lots of risk factors, but you have to understand that 80% of all the cases are CP are due to in utero insult, like there might be cord around neck, or there might be adequate blood flow, or there might be reversal of the blood flow, or the mother has taken any teratogenic drug. So 80% is due to in utero insult, 10% it is the perinatal insult or the neonatal insult, and 10% is post-neonatal, like the patient got meningitis when patient was 10 days old, or the patient had a stroke, or the patient had a severe hemorrhage, IVH, after birth. So all that are the post-neonatal. So you have to understand that the most common is in utero. It is the gynecologist that we have to blame, guys. So please remember. So the damage, the primary insult or the patterns of injury, of the selective neuronal necrosis. That is the main pattern of injury. It is the most common pattern of injury, and historically it has been divided into three types, but two types were recently recognized, though recently means in last 15-20 years. Like recently does not mean last year. It was recently added. Initially only three types. So even your faculties might know three types, but these two types are added later on, like 10-15 years ago. So what are the types? So first one is the diffuse type. In diffuse type, there is a very severe, very prolonged insult. And what is involved? In the damage? So cortex plus deep brain nuclei are involved. Okay, so that is the diffuse injury. The second injury is this is the second injury. I forgot. Apologize for the excitement. So cortex with deep nuclear pattern. So in this cortex with deep nuclear pattern, there is a moderate insult with moderate duration. And third type is deep nuclear with deep nuclear with brainstem, involvement. So in this deep nuclear brainstem involvement, it is a severe and a abrupt or acute insult. Abrupt insult. So these are the primary three types: diffuse, cortical with deep nuclear, and deep nuclear with brainstem. But two more types were added. What are the two types? One is pontosubicular, and the third type is cerebellar injury. A fifth type, sorry, cerebellar injury. Now these are more common in preterm, and these were the newer types of injury. With cerebellar injury, you know that there is atonic CP. Atonic CP is commonly seen with cerebellar injury. So these were the 5 types of injury that I want you to remember. After this, what are the risk factors? You all know the risk factors, yet we will jot them down for your convenience. So they can be divided into maternal, perinatal, and postnatal insult. So what is the maternal insult? Nutritional deficiency is the most common. Nutrition deficiency like folic acid deficiency, iodine deficiency, hypothyroidism, iron deficiency. Then infections. Infections include torch, and they also include chorioamnionitis. Okay, so infection is the second cause. Third cause is maternal diseases like diabetes mellitus, hypertension. Then endocrine dysfunction, endocrine involvement, which includes hyperthyroidism, and even hypothyroidism. Okay, then there are teratogens, like environmental teratogens might be there. There might be drugs that are teratogenic. There might be alcohol. There might be smoking. There might be drugs. There might be X-ray. So all those teratogens are involved. Then older age is associated with worse prognosis. Older age and poor antenatal care. And it includes poor antenatal care. Also includes poor socio-economic status. So these are the maternal factors. Now, what are the second perinatal factors? So perinatal factors includes perinatal asphyxia, okay, then prematurity, IUGR, bilirubin induced neuronal damage, bind, which is, bind is the most common cause of chorioathetoid CP. Chorioathetosis is most commonly seen due to, there were 4 or 5 movement disorders. One was chorea, one was hemivalismus, and then there is chorioathetosis. So the most common cause of chorioathetosis is bilirubin induced neuronal damage. Then there is intraventricular hemorrhage or intraparenchymal bleeds. Then hypoglycemia. Hypoglycemia has a typical history that the patient was preterm and the patient had seizures after 48 to 72 hours. On the third day of life, the patient had seizures. And this is the typical history of hypoglycemia. Okay, so this you have to remember: hypoglycemic, then dyselectrolytemia, then meningitis, sepsis, everything. Okay, so these are the perinatal factors. Postnatal factors are usually either injury or infectious insult. Infections including meningitis, encephalitis, tuberculosis to the brain, then head injury. Then there might be anoxic brain injury like suffocation. Like sometimes what happens is the child is sleeping and mother rolls over the child and suffocates the child. There might be post-operative cardiac arrest, like the patient is undergoing a surgery for tracheoesophageal fistula and the patient went into cardiac arrest during the surgery. So that is also anoxia. So all that is included in the damage to the brains. So that is very important. Now, what are the types of CP? So primarily types of CP, are in 3 types of CP. So there are 3 types of CP. One is spastic, second is dyskinetic, and third is ataxic. These are the primary 3 types, and that you have to understand that these are primary 3 types, and all this are included in this. So spastic might be hemiplegic, or might be quadriplegic. So hemiplegic is unilateral, quadriplegic is bilateral. So bilateral spastic CP is known as quadriplegic CP. So this is something that you might have learned today, or you might know, but it's funny. So then there might be dystonic CP. There might be chorioathetoid CP, and obviously ataxic CP. Ataxic CP is atonic CP. Atonic CP. Now, as you know, all these names you know very good. Now we will get into how to what is the pathology behind the issue and what is the issue over here. So very important. This table that I'm making, please copy it. It will be very, very useful for you. Okay. So first type of CP is spastic diplegic CP. Okay. In that, what is the pathology? What is the pathology? Most common pathology in spastic diplegic CP is periventricular leukomalacia. It is mostly seen in preterms, and periventricular leukomalacia is the most common pathology. What is the etiology of periventricular leukomalacia? So etiology most commonly is prematurity. Okay. And what is the outcome? What is the clinical feature that you see in those patients? So there is visual abnormalities and the patient is hyperactive. So this is what you see in spastic diplegic CP. Now, spastic quadriplegic CP, what is the abnormality? So there is a multicystic, or there are porencephalic cyst, multicystic encephalopathy. Okay, and it occurs due to perinatal. Most commonly it occurs due to perinatal or intrauterine hypoxia. Perinatal or intrauterine hypoxia or ischemia. So that is the most common cause of spastic quadriplegic CP. And here you have decreased IQ, you have seizures, and you have bulbar involvement. Now you have to understand that spastic quadriplegic CP is most likely to have cranial neuropathies and bulbar involvement. If a patient has bulbar involvement, if the patient has cranial nerve involvements, the patient is more likely to have spastic quadriplegic CP. Okay. Now the third CP is spastic hemiplegic CP. Okay, spastic hemiplegic CP. So the spastic hemiplegic CP is due to cerebral infarct or necrosis. Now, why does this occur? This occurs due to hemorrhage in the brain. Or it might be genetic. Okay, it might be genetic. And in these, you have seizures and you have decreased IQ and learning abnormalities. Okay. So in spastic hemiplegic CP, there is some degree of learning abnormality. Though the IQ might not be severely decreased as in spastic quadriplegic, there is some amount of intellectual deficits present in all patients. Okay, now the third one is dyskinetic. Now in dyskinetic, as you know, basal ganglion involvement, and it is known as status marmarota. Ganglia, status marmarota. Okay, and it is most commonly due to bilirubin induced nerve damage. It might be also due to perinatal asphyxia also, but bilirubin induced neuronal damage. Kernicterus is the most common cause, and it is associated with hearing abnormality, sensory neural hearing loss. And it is central in nature. Sensory neural hearing loss. There might also be presence of gaze palsies. Vertical gaze palsies might also be seen with basal ganglia bind, and there will also be associated teeth abnormalities might be there, or the teeth will be abnormal in the patients. And last one is ataxic, and it is due to cerebellar lesion. And the most common cause of cerebellar lesions are genetic. Okay, and it leads to motor delay because the patient is atonic. That is why there is motor delay. So this table is extremely important. And you have to, if you know this table, you probably will do very well. So that is why you remember this. Okay, now how to approach to a patient with CP? Approach to a patient with CP. So firstly, the first question you ask is increase muscle tone in more than or equal to 1 limbs. Okay, so there is increased muscle tone, yes or no? Is that spasticity or no? If the answer to your question is yes, and if the answer to your question is no. So if the question is yes, then your answer will be spastic CP. Spastic CP. And if the answer is no, it is non-spastic CP. Okay. Now the spastic CP, the next question that you have to ask is unilateral or bilateral. So unilateral, if it is unilateral, if it is bilateral. So if it is unilateral, it is hemiplegic. And if it is bilateral, it is quadriplegic. Okay. Now the next question is, if it is non-spastic CP, then what is the status of the tone? Okay. What is the status of tone? And is it variable or not? If it is variable or not. If it is variable, then your answer is that it is a dyskinetic CP. If it is yes, and if it is no, and if there is, if it is no, then your answer is, the next question you ask is ataxic. If it is no, then your answer is ataxic CP or atonic CP. Okay. Now, in case of dyskinetic CP, you asked further more question. What is the question? If there is reduced activity with increased tone, and if there is increased activity with decreased tone. Okay. So when there is decreased activity with increased tone, it is dystonic CP. But if there is increased activity, something like this, then it is chorioathetoid CP. Chorioathetoid CP, and that you have to remember. So this is how you diagnose each and every one of CP: chorioathetoid, dystonic, ataxic, bilateral quadriplegic, unilateral hemiplegic. If bilateral upper limb, lower limb are involved, then it is quadriplegic. If it is unilateral, only one types of limb involved, it is diplegic CP. So that is very important. Now, before we go that, there is a score known as GMFCS scoring, GMFCS score. Okay, so just remember them. I will tell you very easy way. There are class 1 to class 5. 1, 2, 3, 4, and 5. Okay. So in class 1, walks without limitation. Walks without limitation. So 2 is walks with limitation. Okay. 3 is walks with handheld mobility device. Handheld mobility device. Okay. So handheld mobility device. Then class 4 is self mobility with limitations. So powered devices might be required. In class 3, you require crutches. You require crutches or any orthosis, but the patient can walk on their own, but you require crutches or any orthosis. And grade 5 is that you require a manual wheelchair. What does this mean? Is someone is pushing it for you. Okay. So in 4, something like, you can walk. So like the special chair that Stephen Hawking had. So in class 3, you remember crutches. In class 4, you remembered powered wheelchair. Okay. And 4th, 5th one is that someone else is pushing you on the wheelchair. So these are the classifications of the different GMFCS scoring. Now, what are the CP mimics? CP mimics. Okay. So when do you have to rule out CP? Rule out CP if. So there might be 3 possibilities. One is on history. Second is on exam. And third one is on imaging. Okay. Imaging. Okay. So how do you rule out CP? So first, history is Positive history of same disease in family. Okay. If a patient comes to you, the patient is not walking, the older brother has Duchenne muscular dystrophy, then it is not CP. Please. So understand this. This is very important. Then history of consanguinity. Absence of events. So events, which events? That there was no history of birth asphyxia. There was no history, no significant history of NICU admission. There was no significant history of the patient's mother requiring any issues. If there was no history of patient's acquired insult, that patient did not get admitted ever before. The patient had never history of meningitis and all that. So if there is no significant history of such sentinel events, then you have to rule out CP. Okay. And fourth, no risk factors for CP. The risk factors that we noted, no risk factor for CP. Then there is neuroregression. Neuroregression is never seen in CP. Neuroregression is always something insidious. And the most commonly we have been seeing it is leukodystrophies that are usually, if you have a patient of neuroregression, I would suggest personally, my opinion would be telling you that rule out leukodystrophy first, because we have had hundreds of patients with globoid leukodystrophy, metachromatic leukodystrophy, adrenoleukodystrophy, all types of leukodystrophy we have been seeing very commonly, and those have a history of neuroregression. That is why you have to remember this. Okay, then there is episodic issues. Like the patient is normal in the morning, but in the evening the patient stops walking. It is not CP. It is some other issue, muscular issue. It is probably myasthenia gravis. It is something else. So episodic. There should not be fluctuations. Fluctuations in motor. Fluctuation in motor compartment. It is not suggestive of CP. Then there is dysmorphic face. Now this is a double-edged sword. Why? Because see, a patient has a dysmorphic face. The patient might have any syndrome, and due to that, the patient has these issues. But see, those syndromic patients are also at higher risk of getting CP, and they are at higher risk of suffering from parental asphyxia. So when you have a dysmorphic face, after you rule out a syndrome, you have to consider a possibility that this patient, like if a Down syndrome child comes to you and his mother is telling you that there was a history of neonatal resuscitation, the patient was intubated, the patient had seizures during birth, then you cannot be like that okay, dysmorphic face, Down syndrome, it has to occur, it is not CP. No, it can be CP. For some reason, these patients have higher chances of CP, but you have to rule out the syndrome first. Second is presence of neurocutaneous markers, café-Euler spots, adenoma sebaceum, all this neurocutaneous markers. If there is a railroad calcification, if there is a port wine stain, if there is Sjagren's patch, if there is the ash leaf macules, all this, if it is present, then it is less likely. Okay. Then isolated muscular hypotonia. In my lecture of approach to a floppy child, you will see that there are many conditions where you have isolated muscle hypotonia, like spinomuscular atrophy or Down syndrome. All this you have to, if it is isolated, is less likely to be CP. Then paraparesis, peripheral nervous system involvement, like pes cavus, or pseudo hypertrophy of the calf. It is more likely to be Charcot-Marie-Tooth syndrome. Peripheral nervous system is never involved in cerebral palsy. It is cerebral palsy. Okay. Then optic atrophy. So all this you have to rule out, and then you go for imaging. At the last stage, you go for imaging. Okay. So at the last stage, you go for imaging. So in imaging, if there is a normal MRI, if the MRI is normal, or if there is demyelination, or dysmyelination, or hypomyelination, or if there is cerebellar atrophy. Okay, or if there is a tigroid pattern. So if the imaging findings are suggestive of something else, it is not CP. So in these conditions, you have to understand that it is not CP. Okay, so what are the conditions or diseases which mimic CP? Conditions that mimic CP. Okay, so first is if there is a muscular weakness, you have to rule out DMD. You have to rule out neuroaxonal dystrophies. You have to rule out leukodystrophies. If there is presence of dystonia and involuntary movements, dystonia or involuntary movements, if there is a history of same, you have to first rule out Segawa disease. Segawa disease is a dopa responsive dystonia. It is Segawa disease. Then Hello-Verdens-Parts disease, eye of tiger appearance, Hello-Verdens-Parts disease, where there is iron deposition in the basal ganglia. So Hello-Verdens-Parts disease, which is known as pantothenate kinase associated neurodegeneration, PCAN. Okay, it is Hello-Verdens-Parts disease, eye of tiger appearance. Okay, then there might be mitochondrial abnormality like Lee syndrome. And in even melas, there are recurrent brain strokes. That is why stroke-like episodes will lead to neuro abnormalities. Then glutaric aciduria. Glutaric aciduria has a bat wing appearance of the brain, and it also has a history of neuroregression in a patient. So glutaric aciduria type 1 is the most common and most severe. Okay. The next is juvenile neuronal steroid lipofuscinosis. Okay. Then Rett syndrome, stereotypical disorder, neuroregression. We have already, covered it with autism spectrum disorder. Okay, Rett syndrome. Then Perzelius-Murchwacker. And there is also Perzelius-Murchwacker like disease. So PMD and PMLD. There is myelination, hypomyelination pattern. So in PMD, and there is also other disease known as PMLD, Perzelius-Murchwacker like disease. These have a typical history of hypomyelination, dysmyelination in the MRI brain. Okay, that is very important. And even Lesch-Nyhan is the, you might know, it is an abnormality in the HGPRTase synthase enzyme. And there what happens is there is accumulation of uric acid in the body. And this will lead to self-mutilation and neuronal regression. And this partial deficiency of the same enzyme causes a disease known as Keeley-Sigmiller syndrome. And this Keeley-Sigmiller syndrome is a less severe variant of Lesch-Nyhan. Then what is the third condition? Conditions that mimic quadriplegic CP or spastic diplegic CP. Okay. So which are this? Leukodystrophies, all the leukodystrophies. Then arginase deficiency. Arginase deficiency is a progressive, it is a slow disease. It is a slow growing organic aciduria. It is a slow disease. And in this, it mimics cerebral palsy. So arginase deficiency is very important. ELD, MLD, all this are included. Then there is something known as torch syndromes. Then there is iodine deficiency, cretinism. Okay. Then what are the mimics of ataxic CP? Mimics of ataxic CP. So Angelman. It is a uniparental disomy syndrome, and there is deletion of the parent, the father's chromosome 15 is abnormal. Angelman syndrome. They are happy puppets. Okay, then Niemann-Pick type C. Niemann-Pick also has cherry red spot. Okay, ataxia telangiectasia. Ataxia telangiectasia, it is a neurocutaneous disorder. There is increased association with respiratory infections. There is increased association with leukemias and lymphomas. Okay, then NARP syndrome. NARP syndrome. Then what else? Joubert syndrome. Joubert syndrome has molar tooth appearance of the cerebellum. So molar tooth appearance of cerebellum, very important. And there is pontocerebellar atrophy. And two syndromes which might mimic any type of CP is Zellweger syndrome and polymicrogyria. Microgyria is seen with congenital CMV infection and congenital rubella infection. Obviously, CMV is more common, so it is more likely to be with CMV. Okay, so next is what are the predictors? Predictors of CP. What are the early predictors of CP? So what are the early predictors? First is HINE. What is HINE? Hammersmith Infant Neuro Examination. Okay, we will study HINE in detail. Okay, then the second are the Amil-Thiessen scale. Okay, there are muscle angles also, Amil-Thiessen. Then next is Bailey scales of development of toddlers and infants. Then there is a Dubowitz scale. Dubowitz scale of neonatal examination, neonatal exam. Now the most important amongst them is Hammersmith Hein. Okay, Hein. Now what is this Hein? Just remember this Hein. Hein is a score in which there are total 26 items. We check 26 items and we score them on the range of 0 to 3. So the score ranges from 0 to 78. Okay, there are 26 items and each item's score ranges from 0 to 3. 0 to 3. And the total score will range from 26 into 3 is 78. So 0 to 78. Okay. So that is the Hein score, Hammersmith score. And that is again very, very important. Now you have to understand that what are the comorbidities which are associated with CP. There is one more score, Ashworth score. What is the Ashworth score? If you want, you can post. I'll send you the Ashworth score. It is not that important. It is not possible to remember so much. That is why we'll go into the comorbidities. Comorbidities. Now, what are the comorbidities with CP? So the most important comorbidity is epilepsy. Epilepsy or seizures. Rather, we'll not use the word epilepsy. We'll use the word seizures. Okay, so seizures is the most common abnormality that we see in the patient with CP. And what are the risk factors for CP? So risk factor for seizures. Okay, so first is low Apgar, ELBW, or rather ELGAN. What is ELGAN? Extremely low gestational age newborn. That is ELGAN. Okay, so ELGAN is more appropriate term. Then next is if the patient require resuscitation, then family history of epilepsy is positive. Then there is a anatomical defect, anatomical brain defect. Okay, or if there is intrauterine infection or associated with hemiplegic or quadriplegic CP. Or severe intellectual disability. Okay, so that is very important. Now you have to understand that 75% of the patient with this epileptic disorder present in the first year of life. 75% of the people present in first year of life, and this usually require, these are multi-drug resistant epilepsy. We require multiple drugs, to challenge and to treat these patients. Now, what are the seizure mimics? Seizure mimics in CP. We have done an entire lecture of seizure mimics, but seizure mimics in CP is different. What are these? Firstly, that the child is making dystonic movements. Child makes dystonic movements. So it might be, confused with CP. The child, usually many of the quadriplegic CP, you will find the child to be making such noise. See, I'll show you. Something like that noise. So that is a dystonic movement. Okay, then breath holding spells are very common with CP patients. And third is Sandifer syndrome. What is Sandifer syndrome? It is the GERD. It is the neck contortions. There is a neck contortion movement due to GERD in infants, and that is known as Sandifer syndrome. Okay. Then third is if the child is having stereotypical movement like chorioathetoid CP. It is very difficult to differentiate it from seizures because they are making that that movement again and again. That is why it is very, very important. Now, EEG is not important in predicting seizures, but if seizures are there, it will diagnose it. Okay. So that is very important. Treatment is done according to case basis, and that is why it is very important. Now, the next important point is neuroimaging in CP. Neuroimaging in CP is very important. Why is this neuroimaging in CP very important? Because when to do neuroimaging in CP is very important. So first thing is unknown etiology. Unknown etiology. Second is if there is associated microcephaly. Okay. See, in patients of CP, there is no benefit of MRI because see, MRI is very limited. If we go on MRIing every CP child, there is no benefit. See, after doing MRI in the CP, your treatment management will not change. If you think that it is not CP, then it is a good role. Or if you cannot find the etiology, if there is no insult to the brain, there is no history of anything that we talked before, then you can go. The third one is if you have to do genetic counseling. Like if you are suspecting that it is a CP mimic, then if the parents ask you that what is the risk in future pregnancy, then you have to go for MRI. The fourth one is that you seal the diagnosis. Like why it is important. Parents come to you and they hammer you again and again. So you do an MRI. You tell them this is CP, this will not be treated for life, you go home. That is, see, it is an irrational usage of MRI, but yet you can do it. Okay. And fifth is medico-legal case. Medico-legal case, you have to do MRI. Now, what are the investigations that you can do? So firstly, you have to understand that in cranial USG is very important in the perinatal period. Okay. Post-perinatal, we go for CT scan. The yield of CT scan or benefit of CT scan is 77%, and disadvantages is it is poor for dyskinetic CP. Okay, and the advantage is that it is good for hemiplegic CP, and it is good for torch infection where there is periventricular calcification. So it is bad for dyskinetic CP, it is good for hemiplegic CP and torch. But the best investigation is obviously MRI, and in MRI it is yield is 89%, much higher than this CT scan, and it shows you periventricular leukomalacia, and it also shows you dysmyelinosis, it shows you hypomyelinosis, it shows you the basal ganglia and thalamus. So that is the advantage. Okay. So with these done, we will go that what are the comorbidities in CP. So the worst comorbidity in CP is pain. 75% of the patient with CP have pain, and this disrupts their sleep cycle, and this will make them behaviorally abnormal. That is why you have to manage them very, very early. Now, the other thing is spasticity. Now, spasticity can become a big issue to the patients if you do not treat it on time. So spasticity is important. So what is important for spasticity is you give oral meds. You can give botulinum, Botox injection. You can give intrathecal baclofen, intrathecal. You go for surgery and you can go for the physiotherapy. So this prevents spasticity or it treats spasticity. So after this you have done, okay, what is important? So what are the drugs that are commonly used? Oral drugs which are commonly used. So drugs that you used are baclofen, tizanidine, and benzodiazepines and dantrolene sodium. Dantrolene. Now, what is the dose of baclofen? The dose of baclofen is 0.1 to 1 mg per kg per day. Okay. Tizanidine is 0.3 to 0.5 mg per kg per day. For benzodiazepine, we usually give clonazepam, clonas. So the dose of clonas is 0.01 to 0.05 mg per kg per day. Okay, here also day. And the dose of dantrolene sodium is 3 to 12 mg per kg per day. Okay. So these are the previous doses that we give. And you have to understand that what drug to use. Now, how will you choose what drug to use? So in patients with seizures, severe seizures, you avoid baclofen because baclofen is may lead to seizures. It is an excitotoxic drug. Okay. If you have spasticity plus dystonia, drug of choice is baclofen. So when do we use baclofen? We have spasticity plus dystonia in the patient, you give baclofen. If you have sleep abnormalities, you give benzodiazepine. Okay. If you have myoclonus, again give benzodiazepine. Okay. And if you have liver abnormalities, avoid tizanidine and avoid dantrolene sodium. Okay. Now, if you have movement disease, then the drug of choice is trihexyphenidyl. And this trihexyphenidyl is an anticholinergic, which is started at the dose of 0.1 to 0.2 mg per kg per day, up to 1 mg per kg per day. That is the maximum dose, and that is the drug of choice for movement disorder. Trihexylphenidine is very commonly used, or you can give tetrabenazine. Tetrabenazine is a wonderful drug. Valbenazine is also been successfully used for Huntington's chorea. So tetrabenazine is also a very good drug for Huntington's chorea, and the side effects of this drug, these are anticholinergic drugs. So side effects include Parkinsonism. The side effect of all drugs include Parkinsonism. Then you can also go for baclofen. You can go for levodopa, carbidopa combination. So that is syndopa. You can go for benzodiazepine and you can go for deep brain stimulation. Okay. Tetrabenazine, the dose is 0.5 to 4 mg per kg per day, and rest all doses, even levodopa if we start or syndopa if we start, it is 0.5 to 10 mg per kg per day dose. Okay. Rest all dose we have talked about before. Now, what do we do? What are the therapies? What is the rehabilitation and physiotherapy? Rehabilitation that we do, and physiotherapy that we do, and what is the occupational therapy that we do? Occupational therapy, we refer the patient to DIC, then we don't know what they do. So what they do is, what are the therapy methods? So first is Bobath method. Now, what is Bobath method? This is the most common method used worldwide, and it decreases the muscle tone. It stimulates normal movements, and inhibit primitive reflex. Okay, and here what we do, we stimulate key points to, you stimulate some parts of the body to, lead to this. The second method is habit method. What is habit? Hand arm bimanual intensive training. Okay, what is habit? In this habit, a patient of hemiplegic CP is the target. In this, what do we do is we stimulate the child to use both hands. So we tell the child to do drumming, or we tell the child to push the balan, the rolling pin that we used. Okay, balan. So this movement is advised to the patients in habit, hand arm bimanual intensive training. The third one is CMIT, constraint induced movement therapy. Constraint induced movement therapy. In this, what we do, if a patient is hemiplegic CP, we bind one hand. And we encourage the child to use the other hand. So in that, it is very beneficial. Then the fourth therapy is context-based therapy, in which the child learns with respect to the environment of the child. Okay, and fifth is goal directed, in which we decide a goal that we want the child to do this, and it lays emphasis on the activities based on goals rather than using any motor learning approach. So it is goal directed therapy. So both habit, CMIT, context based, and goal directed therapy. That is very important. This is the physiotherapy that are used. Now, now in this, what is the treatment, or what are the various goals? So in two therapies I would like to focus, and these are the newer therapies. So we will focus. So botulinum toxin usage in CP. Okay, so for orthopedics, usually the pediatric orthopedics does this, and here what do we do this? What do we do is that what is the indication of the botulinum toxin, or what is the favorable patient? In what patient we use botulinum toxin? So what is a favorable patient? So first one is that the patient has focal goals, not generalized goals. One or two muscles are involved, and we go for botulinum toxin and we give it to the patient. Or there is increased dynamic muscle stiffness. When the movement is there, the muscle stiffness increase. Or if there is muscular hypertonia with a functional person, in a functional person. So these are the positive factors, and in this, it is a good favorable patient. Now, what is an unfavorable patient, or in which patient we will avoid doing this? So if there are severe contractures, fixed contractures, or if there is bony torsion if it occurs, then it is gone. If there is a bleeding disorder, or if there is a generalized involvement, okay, so then we go for botulinum. Now, in this botulinum, for lower limb, the treatment age is 1 to 6 years, but in upper limb, it is only done in patients more than 4 years of age. So if you inject botulinum in the spine, then the lower parts are involved early, or they are treated early. So it has a very good role in patients who have diplegic CP. Okay, if in that patients have diplegic CP, this is a life-saving method. But in quadriplegic CP or in hemiplegic CP, it might heal one side of the leg, but it will deteriorate the other side leg, plus the upper limb will not be involved. So that is why you have to understand. Okay, and that is very important. Dosing and everything is not very important. How do we give it? What are the surgeries that we give? So what are the surgeries that we do? So we can go for tendon lengthening, in which we do tendo-Achilles lengthening, or we go for muscle release. The contracted muscle we release, or we go for tendon transfer. We implant pronator tendon to some other tendon, like the less used tendon, we do tendon implant. You go for neurectomy. Okay. So that is very important. If the patient has virus, if the patient has a club foot and patient are not being able to walk, so all that management you have to go for. There is also what is the other treatment that we do in the patients of CP, and what are the recent advances in the treatment of CP? So in patients of CP, firstly, initially phenol was used. Phenol was used. Phenol was used instead of botulinum injection, and this phenol was extremely painful. And the limitation of phenol was that it could only be used in motor nerves. So what we did was we put the phenol in the nerves. It would kill the nerves. So the contracture would be relieved. That is why it is important. But then botulinum was important, and botulinum came. And in botulinum, the most the patients with diplegic CP respond fantastically. That is what you should know. They respond fantastically to the this therapy. Now, what is next? You can go for orthosis. What is the orthosis that you use? HKAFO. Okay, it is a metal leather caliper, or you can go for articulated foot ankle orthosis. Articulated foot ankle orthosis. It is known as AFO, articulate foot ankle orthosis. Then there is a new therapy that I want you to know about. It is hippotherapy. What is hippotherapy? In hippotherapy, we make the child ride a horse. Horse riding. A horse is also known as hippus. Okay, hippus. They do not make the patient ride a hippo. They make the patient ride a horse. And in this hippotherapy, what happens is hippotherapy has been shown in studies to improve gross motor function. Now, what are this gross motor function that we are talking about that are improved? So, tone is improved, range of motion is improved, strength is improved, coordination is improved, coordination is improved, okay, and balance is improved. So this is very good, hippotherapy or horse riding. And the studies have found to have many emotional benefits also. So there are also cognitive and emotional benefits, like these patients, they bond with the horses. So that is the therapy known as hippotherapy, and this is a recent advance. So if anyone asks you what are the recent advances in cerebral palsy, please write about this. What is the other recent advance? So next one is SDR, selective dorsal rhizotomy. Now, what is SDR or selective dorsal rhizotomy? In this SDR, what do we do is we do laminoplasty. We resect, we do laminoplasty of L1 to S1. L1 to S1. So this is extremely beneficial in patients with diplegic CP. And the criteria for selection, criteria of the patient for selection is, age 4 to 7 years, spastic CP, and good selective motion, good selective motor function. Okay, so that is the criteria of the patient getting for this SDR surgery. The next is intrathecal baclofen that we talked about. Intrathecal baclofen that we already talked about. Now there are two remarkable important advance in the advance. There are also two advance in surgery, in surgical management of CP. So what are these advances in surgical management of CP? So what are this? We use instrument to do gait analysis. Okay, gait analysis. See, there are no names of this method. That is why I will make you understand the process. So first we do the gait analysis, that okay, what is the issue with the gait? If the patient is swaying, if the patient has no posture, if the patient's posture is lost, if the patient has no gait. So we do instrument analysis for the patients who have gait, and then we do a single event multi-level surgery. And then we we use the artificial intelligence to do all this, and then we ask the artificial intelligence to suggest us what surgery should we do, and then whatever the artificial intelligence tells you to do, you do. So this is the very important thing. And there is another surgery known as orthopedic selective spasticity control surgery, which is commonly known in pediatric orthopedic as OSSCS, which was made by Japanese surgeon known as Takashi Matsuo. This is the this is the typical surgery, and multiple surgeries have been done. And these patients, usually in what patients do we do? So in what patients do we do this surgery? In what patients? So those severely bedridden patients who cannot do simple tasks. They cannot feed themselves, they cannot ambulate themselves, and they are bedridden and they have no scope in life. So in those patients, this surgery has been a remarkable response, and this decreases the spasticity and increases the quality of life in such patients. That is why this surgery has been touted as the revolutionary surgery. Now next, one more important thing complications of CP we would like to just see. So what are the complications of? One is CVI. What is CVI? Cerebral visual impairment. So in this, it is usually the visual impairment in CP is due to cerebral abnormalities. And second is Perisylvian syndrome. Now, what is Perisylvian syndrome? Perisylvian syndrome is also known as Worcester-Drought syndrome. And in this, what happens is, in this, the patient has a pseudobulbar palsy. Patient has a small injury, and then the patient develops pseudobulbar palsy. Okay, there is pseudobulbar palsy and there is mild quadriplegia. So when you score this patient on the GMFCS, they have good ambulation. These patients have very good ambulation because they have mild quadriplegia. But the pseudobulbar palsy this is the issue, and this is neglected in the patient. And what happens due to this is that the patient worsen, and the patient will not take nutrition properly, and patient will worsen. That is why this is a very important syndrome. And the last complication is drooling. Again, in the quadriplegic CP, spastic quadriplegic CP, the patients who have bulbar and pseudobulbar palsy, they cannot take even their saliva inside. That is why you have an issue with drooling. So what are the management of drooling? So first is non-invasive, in which no surgery is required. Invasive, what do we do is we go for proper positioning. We go for good feeding skills. We provide oral facilitation. What is oral facilitation? So we provide them an awareness. We brush their teeth properly. We stimulate the oral cavity so that they can, anticipate feeds. Then a vibration to the local areas. Then oromotor exercises. So this improves the feeding problems in CP, the drooling problems in CP. And management also, you can go for pharmacotherapy, something like glycopyrrolate. So you can also go for that to decrease the drooling. So usually we do not require surgery for the patient, and this is what this is the crux of cerebral palsy. So in recent advances, if they ask you that what is the recent advances in the cerebral palsy, so you are expected to write about intrathecal baclofen. You are expected to write about hippotherapy. You are expected to write about selective dorsal rhizotomy. You are expected to write about these two surgeries. One is AI-based surgery and second is OSSCS. just the names, just the initial detail, and I guess that's all for the recent advances. Obviously, there is no stem cell therapy. See, many places are offering stem cell, Ayurvedic, homeopathic therapy, but they have not proven to be very successful. It is in the pipeline. So you can also write this, that it is in pipeline. It might be developed in the future. And recent advances is that we are mostly, now focusing on prevention. So you have to understand that what are the levels of prevention. What are the levels of prevention of CP? So firstly, you have to understand that primary prevention. So primary prevention has two things: health promotion, that you tell the mother not to smoke, avoid smoking in mothers, or tell them to avoid alcohol, or tell them to avoid the teratogenic drug, or tell them to avoid taking regular antenatal checkups. Okay, let's go in the new page. So primary, in which first is health promotion, in which we tell them that overall health you have to improve, malnutrition you improve, and second is specific protection. That is, you take rubella vaccine, okay, so that you don't have torch. Then you have to take folic acid specifically to avoid neural tube defects. You do universal iodization. So let's write them down. So here, rubella vaccine, folic acid, prevention of CP. If someone asks you that how do you prevent CP? So primary prevention of CP is you do health promotion, you avoid malnutrition, you avoid smoking, alcohol, teratogens. Okay. In specific prevention, rubella vaccine, folic acid, iodization of salt. Okay, iodization of salt. Then go for triple and quadruple tests. Triple, quadruple test. Okay. Then what is the next? You do universal immunization for pediatric patients. Universal immunization of children. It will prevent Haemophilus influenza infection of children. Then you give Rogam. What is Rogam? You prevent RH isoimmunization prevention. Rogam is anti-D, okay? So you do RH isoimmunization prevention by so that you don't have bilirubin-induced nerve damage. Then intrapartum monitoring for fetal distress. Okay, so all these are the things that you have to do for primary prevention. Now, what is secondary prevention? So in secondary prevention, we do early diagnosis and treatment. Okay, so for early diagnosis and treatment, we go for newborn screening for congenital hypothyroidism or inborn errors of metabolism. So that is newborn screening, even galactosemia and everything. Then high risk clinics. Okay, then you go for cervical encerclage. To prevent prematurity. In the mother, if you do cervical encerclage, prematurity is developed. And we have made a lecture of antenatal administration or antenatal approach to prevent prematurity. This is what you should write over here. Okay, so antenatal approach to prevent prematurity, and that is what you go, and even therapeutic hypothermia. And tertiary prevention. What is this? Tertiary prevention. What is tertiary prevention? Decrease the complications. The disease has occurred. You have to decrease the complications in the patient. So that is again very important. Ambulatory support. Okay, and you go for botulinum toxin and all the things that we discussed now to prevent selective dorsal rhizotomy, or the surgeries that we go for. We go for refractory error correction. And we help for occupational therapy. so that they might rehabilitate. So this is what it is all about, the mega lecture of cerebral palsy. I hope that we have probably crossed 1 hour, and I hope you learned something new, and I will see you in the next one.